The time to first antibiotic dose in patients with community-acquired pneumonia is a core quality measure by which hospitals and physicians are evaluated. Might this time pressure have a negative effect on the accuracy of diagnosis of pneumonia? Welcome to the Clinicians Roundtable. I'm Dr. Leslie Lundt, your host, and with me today is Dr. James Welker. Dr. Welker is the director of the Franklin Square Clinical Research Center and has 10 years of experience in managing clinical trials evaluating new medications, including anticoagulants, anti-infectives, and anti-diabetic medications. He practices as a hospitalist at Franklin Square Hospital in Baltimore. Welcome to ReachMD, Dr. Welker.
Thank you for having me here.
Tell us about this time standard for treating pneumonia and how it came about.
Well, in an effort to ensure quality of care in hospitals, there's a number of standards that have been created over the past decade by the CMS. And these standards are largely based on what information we have available. So they have committees that review the information that's available for treating common illnesses. And in the case of pneumonia, they reviewed the information that was out there. And initially they found that patients did better when they were treated within 8 hours of arrival to the hospital, and subsequently they found that they did even better than that, even better when they were treated within 4 hours of arrival to the hospital, receiving antibiotics for cases with pneumonia. So based on that information, they created a requirement that hospitals meet this standard. They have to measure it. They have to report it to CMS, and CMS thereafter reports it on the Internet and makes it available to the general public so they can see how any hospital performs with regards to this what's called core measurement.
Now, what are the potential problems with this time standard?
Well, I think the issue becomes when you set a deadline for clinicians and you have so many variables that can be uncontrolled during that time period that in order to make the standard, clinicians will then, regardless of what information they have available at that time, they make a decision and they move forward with care. And if they only have 80% of the information back, or if it's a less than clear case, they'll give a diagnosis and initiate treatment in an area of uncertainty, where otherwise they may not have chosen to do that. And I think that leads to problems with the diagnostic rates, that their ability to accurately diagnose patients declines, and that's what we suspected, that's what we looked for, and that's what actually we found.
Now, tell us about your study that was recently published in the Archives of Internal Medicine.
Well, this was a retrospective study. What we did was we went back and through medical record review and identified all patients that were admitted to our hospital during the time period when there was an 8-hour expectation. We call it an 8-hour window for receiving antibiotics. Subsequently, when there was a 4-hour window to receive antibiotics. And we did a chart review. And before we began the chart review, we defined diagnostic criteria for pneumonia. We based those off of those that we commonly use for clinical trials that study pneumonia. And then we looked at what was the diagnostic accuracy rate if we applied those criteria to these patients. So we looked at whenever they were initially admitted, the diagnosis was made by the ER doctor, and as well we looked at later subsequent hospitalization. And as well we looked at what discharge diagnosis was applied by the discharging physician. And we looked at all those ways of diagnosing pneumonia by criteria at the time of admission, the subsequent hospital, and then as well the discharge time by the discharging physician. And we compared that for the two time periods to see if the accuracy had declined at all during that period of time. And indeed we found that the accuracy of the ER physician's ability to diagnose patients declined whenever we created a more narrow window for them to make a decision on whether or not to give antibiotics.
Now, was the study industry funded?
There was a small grant from Pfizer Pharmaceutical Company to support the labor we had involved with reviewing the charts. And that's certainly noted in the article. This isn't a treatment trial, and the medicines that we use at this hospital to treat pneumonia aren't even none of them are made by Pfizer. So.
Mm-hmm. If you're just joining us, you're listening to the Clinicians Roundtable on ReachMD XM 157, the channel for medical professionals. I'm Dr. Leslie Lundt, your host, and with me today is Dr. James Welker. We are discussing his research in antibiotic timing and errors in diagnosing pneumonia. Dr. Welker, tell us the results of your study.
Well, what we found was that during the period of time when the window period, or as we call it, another name for it is the time to first antibiotics, was reduced to 4 hours, reduced from 8 hours to 4 hours, that the accuracy of the ability to diagnose pneumonia had decreased. And depending on how you looked at it, it was a change of anywhere from 50 to 70%.
Wow, so a huge change.
So yeah, it was quite striking, and especially with the measurement of at the time at which they were making diagnosis, meeting criteria are commonly used for clinical trials. So that certainly raised some concerns in our minds, and there's been other similar research that has looked at this looked at the impact of this process outcome on care, and there was another article very similar to ours published earlier this year. I think it was in Chest that in a manner looked at it, but just used discharge diagnoses. Didn't take the time to do the careful chart review and create the diagnostic criteria that was used for clinical trials. But similar in concepts and had a similar finding, and then there's been other articles that have suggested that there are, as we change this window of time, more people are being diagnosed with pneumonia and receiving antibiotics and suggested other complications of that, such as increased rates of C. diff and items like this have been written about as well, and their association is less clear because of limitations in studying those sort of outcomes. But all this has led all this information, and I think our article was sort of the final article that has led the CMS to actually change the timing window up to 6 hours. And that's interesting because that's a very arbitrary number. They have
Right.
data where they studied 8 hours, and they have data where they studied 4 hours. And they don't have any data where they studied 6 hours. But I think they looked at it and said, well, our article clearly showed that the ER doctors 4 seemed like too little time, and it was compared to 8. So I think they felt like maybe they picked somewhere between those two that would give them a little more time, and maybe things will be a little easier for them.
So what's the theory behind that? Why is 4 hours not enough time? What happens, in 4 hours that changes if you give them 6 or 8 hours?
I think there's a lot of variables there. I think it all depends on your particular emergency room, how busy you are, how you're staffed, how quickly your various lab tests come back to you. How short your typical waiting time is in the waiting room. I think there's a lot of variables there that affect this. But I think in essence, what you're looking at is you're looking at physicians in a situation where they look at the clock and say, it is, I have to give this patient a diagnosis and give him antibiotics because my time's up, and therefore I'm going to do so. And so I think as we look at this, and I don't want this to be misinterpreted, I think it's as soon as someone's diagnosed with pneumonia, they should get antibiotics, and the sooner they get them, probably the better their outcome's going to be based on the data showing that patients do better if you get antibiotics sooner. But I think where we run into a problem as a healthcare system is whenever we take and try to apply that information universally to an entire ER, or in this case, all ERs in the country, and that gets into this part where physicians need to have the time they need to make diagnoses and make them accurately. And then once they make the diagnosis, they should treat the patient immediately, but they need the time that they need in order to accurately diagnose the patient.
What lessons have we learned from all this about guideline creation and performance measurement?
Yeah, I think that's a very interesting question. I think where we are is we're just realizing that as we apply these standards to the healthcare system as a whole, meaning across the country, we don't necessarily know that the outcome is going to be as good as what the research suggests it's going to be. And I think this gets into this concept of I think that Watarsky wrote an editorial about our article in Archives, and he titled it "Measuring the Performance of a Performance Outcome." I think there's a realization now that we have to be doing that. We have to implement process outcomes and to be able to standardize our hospitals and measure them. At the same time, we need to have a design in place to measure that and ensure that there aren't unintended consequences of the outcome, and ensure that we are getting the benefit out of the outcome that we expect to get. Because these outcomes, for example, the pneumonia outcome was measured retrospectively in Medicare patients, and so then you take and you apply that outcome that was predominantly a group of people over the age of 65, and you apply that to an entire emergency room, which has a variety of patients in it. So you have to realize that that the outcome may not be what you desired. So hopefully in the future, my hope is in the future that they implement an outcome at the same time when they arrange the process outcome, they arrange a method of measuring all the potential consequences of it, intended and unintended, and then of course at the same time that means arranging the funding to ensure these studies are done, and working with institutions that are capable of completing them, and ensuring that these process outcomes their performance is measured at the same time they're implementing them.
Makes sense. Now, any other words of wisdom, if you were king of the guideline committee, that you would suggest in the future how we can learn from our mistakes?
I think that that's my biggest point or those 2 points are my biggest points, is that specifically with pneumonia, that we should make sure physicians should defend their need to have adequate time to diagnose patients and begin treatment. And then when once the diagnosis is made, their treatment should be done immediately. And on the other hand, this issue of, as a country, we need to be measuring the performance of our performance measures.
Makes sense. Well, thank you so much for being on the show today.
Oh, thanks for having me.
We've been discussing the antibiotic timing and how it may lead to errors in pneumonia diagnosis with our guest today, Dr. James Welker from the Department of Medicine at the University of Maryland. I'm your host, Dr. Leslie Lundt, and you've been listening to the Clinicians Roundtable on ReachMD XM 157, the channel for medical professionals. To listen to our on-demand library, visit us at reachmd.com. Register with the promo code RADIO and receive 6 months of free streaming for your home or your office. If you have comments or suggestions, please give us a call at 888-MD-XM 157. Thank you for listening.